I'd like to welcome everyone to Grand Rounds and introduce Dr. Wong. So as many of you know Dr. Wong, he's received his internal medicine resident training in cardiovascular disease fellowship training at Erlanger, and he was one of our best fellows and left and went to Bay State Medical Center, went on to do his interventional training and came back and is now one of my partners. So we're very glad to have him back, and he's here today to present on the advanced treatment for acute pulmonary embolism. Thank you, Dr. Wong.
Thank you, Dr. Mannion. So today I'm going to talk about advanced treatment for acute PE. Dr. Mannion and our group always have a passion to provide a better care for PE. So I'm going to talk a little bit more on how we are going to help for this disease. I have nothing to disclose, and I'll go over a little bit about epidemiology of PE. So every year, about 150,000 to 250,000 hospitalizations because of a PE, 60,000 to 100,000 deaths because of a PE every year. It is the third most common cardiovascular death. It's behind STEMI, acute MI, stroke, and then PE. 7% in-hospital mortality for all PEs. And 33% in-hospital mortality for unstable patient. That's what we usually call a massive PE. So why do PE patients die? There are two main reasons. The one reason is the mechanical obstruction. So essentially the blood circulation from the right side to the left side, if it is completely cut off in the pulmonary trunk, then that can cause a cardiovascular collapse, and then patient just die. A second mechanism is RV failure. So the RV failure from PE is a cascade. If there is a PE in the pulmonary trunk or in the pulmonary artery, it will cause increased RV afterload, will cause RV dilatation, and then progress into high RV oxygen demand. That would eventually lead to RV ischemia and reduced RV contractility, reduced RV output. If the RV output is reduced, the LV output will be reduced. If LV output is reduced, then the coronary artery perfusion will also be reduced. Therefore, it can worsen the RV injury. So it will become a vicious cycle. Eventually, patient die. So clinically, we usually see those patients with a worsening PE. We can see persistent hypotension and obstructive shock, as well as a cardiac arrest. So those three phases. When patient was in persistent hypotension, the blood pressure, systolic blood pressure drops below 90 millimeter mercury. If continues to have hypotension, they may require vasopressor and organ hypoperfusion. So those are obstructive shock phase. And then if at this phase nothing can help the patient eventually will go into cardiac arrest. So that's one of the cause of PEA. So clinically, like before patient goes into those three phases, we in the ER or on the floor, we have a score to stratify the risk. That's called a PE, Pulmonary Embolism Severity Index, or PESI score. So the score ranges from from 0 to more than 125 points. And it was classified into 5 classes. Usually, anywhere above class 3 is considered moderate and higher risk. Okay, so class 3 is 86 to 105 points. Class 4 is 106 to 125 points. So essentially, anything above 86 is at least a moderate mortality risk. So that carries a risk of 3 to 7% 30-day mortality. Then sometimes, for young patient, the PESI score tends to be low because in PESI score, age is one of the main component. So for those patients, we may also consider to use a simplified PESI score. So for simplified PESI score, if the number is more than 0, it carries a mortality risk of almost 11%. Another thing for those stable patients, we found out may help to stratify the risk is RV dysfunction or troponin elevation. As we can see on the right side of the graph, with the normal RV and troponin, the hazards is relatively low. However, if patient has RV dysfunction, either RV dysfunction or troponin elevation, the hazards ratio is 7.9. They have almost 8 more times of poor outcome. And then if they have both RV dysfunction and troponin elevation, that hazard ratio went up to 14%. So there are many trials to look into the relationship between RV-LV ratio to the PE-related mortality. And the meta-analysis shows that the high RV-LV ratio is significantly related to PE-related mortality. So the cutoff from the literature is 0.9. So anywhere for RV-LV ratio more than 0.9, it is a high-risk feature for PE patient. So this is the way to measure the ratio. So essentially, we on the CT scan, we get to the slide where the tricuspid annulus and mitral annulus are on the same level. Then go 1 centimeter above, and then measure RV and LV dimension, and then use that as the ratio to calculate the ratio. So if we summarize all of those information, we can develop the PE risk. So the PE risk range from low, intermediate, and high risk. So for the low risk, essentially it does not have any feature of what we mentioned before. The patient is stable. The PESI score is less than 86, and there is no RV dysfunction. There is no troponin elevation. So for intermediate risk, we subdivide into intermediate high and intermediate low. So the intermediate low risk only has a high PESI score, or one of the positive for RV strain or troponin elevation. One of them is positive. So this is considered as an intermediate low risk. So for the intermediate low risk, the recommendation is to admit to the hospital and monitor, treat with heparin and monitor. So the intermediate high risk, is the ones who are hemodynamically stable, but they have all other high-risk features, which including high PASI score, RV strain, and troponin elevation. So this intermediate high risk is usually what we call submassive PE. Then the high-risk PE is the massive PE. So those include unstable hemodynamics, which means a patient has hypotension, requires pressure. So next we will get on to the treatment for the PEs. For those, so today I will be focusing on the high-risk PEs and intermediate high-risk PE. So essentially it's a massive PE and submassive PE. Those are the acute PEs we deal with in the hospital. So for the massive PE, the definition is hemodynamically unstable with PE. So usually it is main trunk involvement. So here, like we can see, there is a saddle PE. So the key to massive PE is to reperfuse pulmonary artery as soon as possible. So traditionally, like we use a heparin to treat, but the mortality was very high. Then in 1970s, people start to think about thrombolysis. So the mechanism of thrombolysis is to activate plasminogen and to generate a plasmin to dissolve the fibrins and then degrade the blood clot and achieve a reperfusion to the pulmonary artery. So by guidelines, the first-line treatment so far is Optalyse plus heparin drip. However, if we dig deep into this guideline, and we actually found out the major evidence for this recommendation is from this article published in 2004. It is a meta-analysis on the PE treatment. So in this meta-analysis, they actually included all of the massive PE and submassive PE. So they got, I think, they got like 11 randomized clinical trials. So 5 of them have massive PE, 6 have a submassive PE. They lumped together, compare with thrombolysis versus anticoagulation alone. So they found out there is actually no difference between the treatment, no difference for the mortality. So then they look into the 5 trials, as I pointed out here. So the 5 trials with a cross here, 1, 2, 3, 4, and 5 here. When they lump those 5 trials together, they found out, so those 5 trials all have massive PE. They are unstable. So they found out there is a signal for like a mortality benefit with thrombolysis. However, when we look into those trials, all of them are done like in majority of them are done like in 1970s, and none of them used TPA. Like all of the first one was using urokinase, the other ones use a streptokinase. Even for this one, it's a streptokinase. So none of them were using TPA TPA. That's number one thing we need to pay attention to. Another thing is the sample size are very small. So the first trial had 160 patients, but the other four had like a 30, 25, 31, and 8. Okay, only 8 patients for the last trial in 1995. So when they lump those together, actually the all-cause mortality for thrombolysis treatment is not statistically significant. There is a trend for significance, but it's not a truly statistically significant. The confidence interval included 1. And also, if we look into those, when they lump those trials together, really the trial was driven by this small study with 8 patients. So it's a completely like a biased by this one trial. And so, however, when they look into PE specific mortality, there is a statistical significance for like for mortality with thrombolysis. So overall, like those made the guideline recommendation for TPA treatment for massive PE. And so far, TPA is the only approved thrombolytics for PE by guideline. Then people also looked at submassive PE, and we can see like so the concept is still to see if thrombolysis benefits submassive PE. Again, the data is similar to massive PE. It's like there is a trend for mortality benefit, and especially like if you look into intermediate risk for PE specific mortality, actually like for based on meta-analysis, there is a benefit with thrombolysis. Then in 2014, in Europe, the researchers started this trial. It's called a PEITHOS trial. They want to figure out if TNK, tenecteplase, if that has a benefit in submassive PE. So they designed the trial using half dose TNK in submassive PE, compare with heparin only. What they found is there is no mortality benefit. So between those two groups. However, there is mortality benefit for hemodynamic decompensation, which means in the thrombolysis group, there is fewer chance of crashing. So the TNK rate for crashing is 1.6%, but in the heparin only, it's 5%. There's almost like a 3 times higher in the heparin group. So there is a potential benefit for TNK in submassive PE to reduce hemodynamic decompensation. However, it is not without a cost. The cost is huge. It is like in the TNK group, there is a much higher hemorrhagic stroke rate. It's 2%, and in placebo only 0.2%. That's 10 times higher for intracranial bleeding. So therefore, no thrombolysis is approved for submassive PE at this point. Okay. So now according to the guideline, right now the treatment is still thrombolysis for acute PE, acute massive PE, and heparin for submassive PE. So then we would like to ask if there are any other advanced treatments for those intermediate or high-risk patients. As I mentioned before, the concept for those acute PE treatment is to achieve pulmonary reperfusion, right? So the anticoagulation and the thrombolysis are all reperfusion by medicine. It's a pharmacological reperfusion of PE. So then people were thinking like, if there is a better way to achieve that, so they developed this ecosystem. Essentially, it is a combination of a ultrasound catheter, and a infusion catheter for TPA. So the infusion will be direct infusion of TPA. The purpose is to like increase bioavailability for treatment and also reduce the dosage of TPA. They want to see like if this works. So the ultrasound essentially to loosen the fibrins. You can see like on the left side here, that's without ultrasound, and this is with ultrasound. So the fibrin is loosened with ultrasound, and then it will allow the TPA to go into the fibrins to degrade those fibrins and achieve reperfusion. So the multiple trials were conducted. It's not for like so those trials were initially just to see like a feasibility and also to see if it will improve hemodynamics and if it will improve RV dysfunction. So they randomized 30 patients on the ECOS arm. This is the ULTIMA trial. So all of the patients had a RV dilatation, and the control arm is the heparin. And they look into like the RV-LV ratio improvement at 24 hours, at 90 days, and also look at the complications and long-term RV function. So all of those, the ECOS group had significant improvement. And also in the ECOS group, there is no major bleeding. There is no intracranial bleeding. There is no death. There is some mild bleeding, minor bleeding, which is actually lower than the heparin group. So the heparin group had one mortality actually. So they also conducted a trial for massive and submassive PE with ECOS. So for those patients, they had a symptoms onset less than 14 days with RV dilatation. So they give TPA for 12 hours if it requires 2 catheters. And if it's one catheter, they give 24 hours. So what they see is there is a significant improvement of RV strain. There is significant improvement of pulmonary artery pressure, and also has reduced obstruction. But none of the trials addressed the mortality, the outcome, true hardcore outcome like mortality. So then there were also other registry study which found for those high bleeding risk patients, if they are contraindicated for thrombolysis, when they treat with the ECOS, actually like they had a very good response. So 9 patients received either ECOS or catheter directed thrombolectomy. 8 8 out of the 9 survived. 1 died of massive PE. As I mentioned, normally those patients have 33% mortality. So they also looked into the patients who failed thrombolysis and then use ECOS to rescue. All of them survived and had a good outcome. So then people looked into observational study, and there are multiple trials, multiple studies to show the propensity matched study for mortality, complication, and the readmission rate. For all of those, the ECOS group has a much better outcome. However, none of those were randomized control study. Then they looked into if there is an optimal duration of ECOS catheter, and to further reduce TPA dosage, and also reduce the duration of the catheter time. So eventually what they found is for the 6-hour regimen, which means for each catheter use for 6 hours, they have a similar outcome for RV improvement, and they have less hemorrhagic events. That's why that's what this trial showed, Optalyse trial showed. So that's what we are using in this institute right now, 6-hour ECOS treatment. So far for ECOS, we can treat a submassive PE. Sometimes we can treat massive PE either as a primary or a secondary option. We can also use to rescue for thrombolysis failure. There are other catheter-directed treatment. So those are large bore aspiration catheters, which including angiovac, and here we do that occasionally, and also penumbra and FlowTriever. So all of those are advanced treatment for acute PE. So the opportunity number 2 is there a better system or strategy for acute PE? So the reason we raise those questions is we now have a lot of available options. We have anticoagulation plus systemic thrombolysis. We have catheter-directed treatment. We have catheter embolectomy. We have surgical embolectomy. We also can provide mechanical circulatory support device for unstable PE patient. However, despite of those new options, the mortality remains high, and there are still a chronic PE patient. That's about 2 to 4%, and also some PE patients, they continue to have post-PE syndrome. So therefore, we are calling for the multidisciplinary rapid response team for PE. So this concept essentially is to mimic the heart team approach for a cold STEMI, and also to mimic the rapid response team for the pulmonary resuscitation. So for this PE or PERT, PE rapid response team, it will be involving multiple parties, which range from the emergency medicine, hospital medicine, the primary team, the cardiology, interventional cardiology, pulmonary critical care, vascular surgery, pharmacy, and interventional radiology, and also general radiology, eventually also hematology to look for the cause. So the definition of a PERT is an institutionally based multidisciplinary team that is able to rapidly assess and provide treatment for patients with the PE. There is a formal mechanism to exercise a full range of medical, surgical, and endovascular therapy. Provide appropriate multidisciplinary follow-up of the patient. This is actually one of the key too. We need to continue to provide PE treatment even as outpatient to prevent CTEPH and also follow on the results. If feasible, we also need to do like a QI to provide research data and to develop a new treatment. So this PERT concept came up in 2013 first at MGH, and now 7 years passed, and it was now I think there are 33 in hospitals apply this PERT system in the country right now. So they give out a survey, and 89% of the physicians surveyed believe PERT helps patient care in high-risk PE patients. 71% in favor broad implementation of a PERT. But because this is so early, there is no real outcome data to back up. So tentatively, in Erlanger, we are trying to develop a protocol for PERT. It's still under development, and this is a draft. So I will show you a case to see how we approach those patients. So this is a 32 female, had a history of factor V Leiden, type 2 diabetes, presents to the ER with chest pain and shortness of breath for 2 days. So on arrival, her O2 saturation was 80s. CT showed extensive pulmonary embolism with RV enlargement. Blood pressure is stable. Troponin is elevated, 0.35. So this patient, by using a simplified PASI score, her score is 1. So it's a high-risk patient. And CT scan showed RV enlargement and had a troponin elevation. So this is a intermediate high-risk patient. So this is her CT scan. We can see she has a cytoemboli, involves both right and the left main trunk, as well as the pulmonary main trunk. So when we measure the RV and LV dimension, the RV dimension was 54 and LV was 32. So it's far more than 0.9. Therefore, according to this algorithm, so the patient had PE, she was on anticoagulation. She was put on anticoagulation. And then we look at if the patient is stable or not stable. If the patient is not stable, they will go to pulmonary critical care pathway, get considered for a thrombolysis. However, this patient is stable. Therefore, we need to evaluate the PASI score or simplified PASI score. So this patient is considered high risk, and then general cardiology consult was made, and we evaluated the patient. The patient had RV strain, had troponin elevation, and had a main trunk thrombus. There is no thrombus in transit. Therefore, the patient, the cath lab was activated, and the patient was brought to the cath lab and got echoes. So this is what we do in the cath lab. We put 2 catheters in, and then start ECOS, start a TPA infusion. So for each side, it's 1 milligram per hour. So we give infusion for 6 hours. And in the same time, put patient on heparin drip. So the total amount of TPA the patient receives during the treatment is 12 milligram over 6 hours. And so the patient had a immediate response with the catheter. You can see the heart rate, right? So once the ECOS, I think the ECOS was put in around 6, so around 7 o'clock. So the ECOS, after like 6 hours, patient's heart rate become normalized and respiration normalized, blood pressure stable. A month later, so the prior to ECOS, the mean PA pressure was 25, and after ECOS, the mean PA pressure was normalized, 14. The patient was discharged home in 48 hours. So a month later, the patient came to the hospital for another reason. At that time, she got another CT scan. So we measured the RV and LV ratio. It is less than 0.9. The RV dysfunction has completely resolved. So that shows like with a PERT system and advanced treatment, we probably can provide better opportunities for acute PE patients.